speaker will be Dr. M.FAROOK team. Pediatric consultant. And this topic will be about the SMA is a challenging subject.
Assalamualaikum warahmatullahi wabarakatuh. Good morning to everybody. Respected Medical Director Dr. M.FAROOK, Honorable Judges Dr. Talal Qureshi and Dr. Talal Qureshi, Organizing Chairman Dr. Jilani, my dear friends. At the very outset, I would like to tell that my session will be mostly interactive. Am I well heard in the last benches? So, to start with, I will be putting a session and you will be telling what it is about. We go to the counseling room of the intensive care where the apprehensive parents are waiting, and the doctor enters with the result. Ask the mother, what is the result, sir? Please. The doctor sits down with the head bowed and tells, I'm sorry, the result is positive. The mother, unable to take it, coming to know from the internet and other peer groups that this disease has a great mortality within the first few years. So my topic and the presentation I give initially, the setting, can anybody tell what that is for? It is the breaking bad news. So from this torrid start, I would like to tell that why I present this topic. The thing is, now to the good news. When the results come for this SMA and the tough management, where we are measuring in terms of mortality, you will come to know finally that this hospital, as our director was telling, has the best management not only in the city but in comparison to the best institutions all over the world with the most advanced technology. This will be the final result when I produce you the statistics. So, progressing from here, the first thing which I will be showing is how I will send my format of presentation this time. It will be the declaration initially, the abstract, the definition, the introduction, the features, the manifestations, the purpose, the methods, the material statistics, the results, the conclusion, discussion and questions finally. I have nothing to declare, there are no conflicts of interest. My study, this happened to be a review article and is not funded. And I acknowledge the management for giving me a platform to present our work. The abstract is about the challenges we face in managing SMA. When I extrapolate this is in terms of how the results are as in terms of mortality. Not only it is a challenging condition, the predisposing factor is consanguinity, and this is rampant here, and we have to counter it. These children of spinal muscular atrophy are born normal, and the first mile in the developing milestones, when they give to their parents, that is the one which lingers in the minds of the parents, and they would not like this lingering smile to disappear within a few months or years. That keeps them going, and that is the most problematic situation in terms when you have to tell this dreadful news that the gene test is positive to the parents. This normal born intelligent children are usually detected by a probing obstetrician antenatally. And then an intelligent mother feels the paucity of movements, where the movements are less. And finally, when they do give birth, they progress in an ascending way from the lower limbs. I will just give a brief introduction of this, just to revise what is in your mind already and talked before. It starts with the respiratory muscles, and then to give the support, V-intensive is coming. And here, with the involvement of the multidisciplinary team, we do the proper management till God has written the day of departure. We try to prolong as much as we can, and that we have done in our intensive care unit to the best of our ability, and your statistics will show. This definition, it is a neuromuscular disorder with hypotonia and weakness, and it is characterized by degeneration of the anterior horn cells in the spinal cord. And these are the features, and I would like to show you that the pathology where it is, the anterior horns. There, the situation develops further. Also, there is motor nuclear involvement of the lower brainstem. It results in progressive muscle weakness and atrophy. This disorder is caused by a homozygous deletion of exon 7 of the survival motor neuron gene located in chromosome 5, short arm. The incidence is 6,000 to 10,000 neonates. It is slightly less than the 1 in 4,000 congenital hypothyroid. And based on the diagnostic criteria, according to European Neuromuscular, the SMA type 1, which I will be discussing, the wording Hoffman, shows overall muscular weakness and hypotonia, and they develop within the first 6 months of birth, and usually they never sit by themselves. So these are the main features: fatigue, difficulty chewing, breathing difficulties, gastrointestinal scoliosis, and it continues. The various involved areas: cardiovascular, brain, lung, kidney, and all. Briefly, I have given you an introduction, and the proximal muscles are more involved than the distal. And there is the gastrostomy support we give. The purpose of my presentation is the life expectancy of patients with SMA is generally considered to be less than 2 years. With the introduction of proactive treatments, which I will be mentioning further, a longer and an improved survival rate has been reported. In my study, we have analyzed the natural course and the survival statistics of type 1 patients and compared the clinical characteristics of patients based on the survival period. The methods. What I have done is, I have reviewed the medical records of pediatric patients diagnosed with SMA type 1, examining their demographic and clinical characteristics, calculating their survival probabilities, and plotted the survival curves. I compared the characteristics of patients who died before the age of 24 months, 2 years, that is the early death group, and the late survival who survived 2 years and beyond. Taking our 2 patients as the control standard, we have Master H, and a staggering 5-year survival is there. This is all the more significant in our hospital, and I attribute it to our staff here, the toiling nurses, the doctors here who have managed well, and I would like to give you all a that they require a standing ovation for the work they have done. And these 2 patients are all the more significant because when I come across later on in my statistics, it will be proved that the main factor which is there was also against us in managing these patients. Especially This, especially this patient, Master H, he had a birth weight of 2 kilos only. He was a small baby at birth. And another one, Miss B, age 3 years. And as I have said, that they need a great amount of appreciation for the work done in our ICU, 16 bedded, which is the best, as I have already clarified. The statistics I have used is the survival probabilities at different ages. You will see that where it started, the survival probabilities at 6 months and at 1 year is 92.9. It decreases by 16% as we reach 1.5 to 2 years, and further 9% when it reaches 2.5 years. So it is inversely proportional to the age, the survival probabilities. And I have used the Kaplan-Meier method for, if anybody wants further clarification, I can discuss with you all in private after that. This was the results of the survival probabilities of my situation, which is this SMA type 1. And here I have taken the factors each, for example, the sex, the survival status, this is the early death and this is the long survival. The age in months, the gestation period, these are the variable factors taken into consideration. The birth weight, the age at onset, the age of diagnosis with the SMN gene, which is head control. Usually head control is the first milestone to be achieved. Bobbing head, usually by 3 months they start to develop it, but that's all they achieve. Later on this disease onset and then they start to develop. The support is there. When they go in for respiratory muscle failure, it is the ventilation, invasive or non-invasive, the artificial feeding and the genetic testing. In this, compatibility is there. You will know that the early death, the features are here, which shows that the only probability, one factor counts, which I will be showing you later. Here I have taken the demographic characteristics of patients with SMA according to the duration of survival. You see, among all the features, the sex, the gestation period, the birth weight, the head control, the starting of onset of milestones, the age and symptom onset, the age at diagnosis, respiratory support, artificial. Only one factor counts, and which was against us. And you all know which it is, because the p-value here in the birth weight is less than 0.05. The p-value is only significant when the birth weight is there. It is 0.048. So even this birth weight was an adversary in the patient which we have managed, but still we happen to do much better. The results of my study. The mean survival time was 22 months plus or minus, that's approximately 2 years. The survival probabilities at the birth weight was the only factor which showed a statistically significant difference between the early death and the long survival groups. This is despite the best treatment modalities like intrathecal Spinraza. This is a very costly drug, but it is ineffective when once the ventilation sets in. Those studies are going on for its use even during ventilation now, but results have not yet appeared. And then the FDA approved IV Zolgensma and oral risdiplam, that's trade name is Eviridis. Early diagnostic facilities like invasive ventilation, gastrostomy feedings, these are used to prolong life. Repeated swab and partial septic screens. In this regard, we take the help of Dr. Talal, especially with the antibiogram from our local hospital and the conditions, and we immediately are aggressive whenever the antibiotics are needed. We see that these long-term patients, the bed sores are managed well, and if anything features suggestive that infection has come, we are more proactive, and that has in fact resulted in the better survival of our patients in these two. The thing is, this study, what I am doing, is a retrospective, in the sense that the cases are few, it is a rare situation, and then it needs a long period of study. These are the factors which were hindrance to my study, and I would like to give the due credit to our toiling nurses who have the best ability also in our co-management with them. Yes, and this is a great achievement from we Hamadians, as our organizing chairman was telling, that we have done the best to our patients. And why I have presented in these two cases is that when we take or extrapolate this to the care of our other admitted acute and chronic long-term LTAPU, we appear that we have the best care not only in the city but in the whole world, taking the statistics into consideration. And a relaxation from the statistics. This is Taj Mahal, and I will tell you how to visit and when to visit after my talk, whoever is interested. In conclusion, I would like to say that the survival probabilities at 2 years were far greater than expected for our two patients. Because of the limited number of patients and the information in the study, the contribution of improved supportive care on long survival could not be clarified. This may be only elucidated in larger cohort studies which are going on, but basing on the PubMed and the manuals which I have screened through to get the comparison of the patients and their various management protocols, I could collect about 7 or 10 as I have presented. So this is the one which I had done previously in an American academy, and I had put my previous institution on the world map, and I got the first prize there. Of course, it was a gift of $75. Hopefully the prize money will be more for this regard. And my all regards and patience with all the hearing you had given to my presentation. I thank the management and the organizing committee for giving me a chance. And this is my talk as regards. Thank you very much.